Hilton didn't, and so I keep doing all of this paperwork. So there isn't one.
No, because of the
Because they're going down there.
yeah, everybody do that.
What time is that?
12.
What?
You want to come?
No. What? I have to eat at 12. I've been doing that intermittent fasting thing.
Does it work?
Yeah. Will you shut that, please? Thank you. Peace out, Rom. Hi, Sam. Huh?
Hey, Laura.
Peace out. Peace.
Peace out. Yeah. Peace out, bitches. I'm sorry.
You ruined my recording.
No, you are recording?
No, I'm not. I'm not recording.
That's recording. Nobody would be surprised if they heard that on a recording from me anyway. So. You know. Oh, let's see.
Okay, we are now live on Facebook and we are recording. So let everyone know. And if you're all ready, we can go ahead and get started.
Do we have Dr. Vander Heide?
Yeah, Dr. Vander Heide is no longer with us, Sam.
Okay, we can give him a second.
Yeah. He may need some help.
Okay, I think we're
I
ready.
don't know if you're in. Are you in?
Yeah, I'm in now.
Okay. All right, I'm gonna hang up. Okay. Can you turn on your video, Dr. Vander Heide? Dr. Vander Heide, you have to unmute your microphone.
Yeah, I don't have video, so it's probably not going to work.
Okay, no problem. We can hear you though.
Yeah.
All right.
Okay, are y'all ready to start? Everybody feel good? So we'll get started, Dr. Vander Heide, and then Crystal will introduce y'all. So I just have a couple messages before we start, and then Crystal will introduce you and Dr. Fox, and then y'all can begin. And I'll stop screen sharing.
Okay.
Okay, Jenna, can you let everyone in, please, and we can get started? Okay, welcome everyone. Sorry about the late start. We just had a few difficulties. I'm so sorry about that. I know that is such a pain for everybody. I just want to let you know that I am showing my screen that this is available for CME credit. If you do want that credit, please change your Zoom name to your LSU email address. And there's also information in the chat about it. And I will take this off now. Okay. And I'd like to introduce Crystal Oliveira. She's our Chief Development Officer at LSU Health Foundation.
Thanks, Sam. And hello, everyone. Thank you for joining us on our ongoing COVID-19 web series. I think this is our 16th webinar. Is that right, Sam?
I think so, yeah.
And we're glad you're here and thanks for tuning in. Today we have two very special guests. They are our Dr. Rick Vander and Dr. Sharon Fox from the Department of Pathology. And they are studying the first series of autopsies from COVID-19. They've been on the news and a few articles have been written about their findings, and we're excited to have them today. Welcome, Dr. Vander and welcome, Dr. Fox.
Thanks, Crystal.
Thank you. Okay.
Okay, y'all want to go ahead and share? Oh, you got it? Great.
You got it?
Yep.
All right, yeah, it's showing.
Okay. So let me just reduce this. This is Dr. Fox. I'm here with Dr. Vander and thank you for coming to hear this webinar. It's the first autopsy series of COVID-19, what we have learned at LSU Health Sciences Center. So in this brief talk, we'll talk about what we have done within the department at LSU for our autopsy service in preparation for the coronavirus pandemic, the pulmonary pathology of severe COVID-19, our initial findings in cardiac pathology, as well as clinical implications and future directions. So when it was first clear that the coronavirus pandemic was making its way into New Orleans, we sat down and decided that it would be important to come up with a protocol for our autopsy service, which was an ongoing service, to be able to handle patients who may be deceased due to coronavirus and the infectious disease implications of that. So Dr. Vander drafted a protocol based on the fact that our new morgue at UMC has negative pressure ventilation and is able to handle these types of infectious cases. And that occurred in early March. We also added additional PPE, N95s and protective body coverings, in addition to extra gloves and boot covers. And you can see a picture of our team on this slide wearing some of that protective equipment. We limited the number of personnel in the morgue during these cases to the minimum number required to do the case. And then on March 19th, we actually had the first autopsy of a patient who is deceased due to coronavirus. Our first series that we studied included 10 patients from approximately that time until April 3rd. And since that time, we've had many more, have been producing these studies in an ongoing manner in addition to performing autopsies on these patients. Our first paper, which is what we're going to discuss today, was recently published in Lancet Respiratory Medicine. It's titled Pulmonary and Cardiac Pathology in African American Patients with COVID-19, an autopsy series from New Orleans. And in this paper, all of our patients were African American. They were both male and female, and ages 44 to 78. This was actually reflective of the dominant demographic of deaths that we were experiencing at UMC as well as in New Orleans on the whole due to the COVID-19 pandemic. All of these patients had at least one comorbidity, and the most common being hypertension, type 2 diabetes, and obesity. Importantly, none of these initial patients were hospitalized or in a nursing or assisted living facility prior to the infection. Most of them were active and going about their daily lives. So we didn't have a lot of other diseases that may create confounds with our analysis of the pathology. The patients, there were numerous laboratory findings described in this manuscript. Important ones included an elevated D-dimer in most of the patients that were measured, as well as fibrin and fibrinogen, but with minimal to no elevation of PT or PTT. Also, many of them had a relative lymphopenia near the time of death. And these are our gross findings from the lungs. And that included edema. The lung weights were approximately 1 standard deviation or more above normal. There was significant hemorrhage, as you can see, don't know, on the picture on the left, a darkened appearance to the lungs, as well as a lot of red areas. And then also small vessel thrombi. And those are indicated by the arrows on the right, particularly in the periphery of the lungs. On microscopic exam of the lungs, one of the first things that we noted was diffuse alveolar damage. And this has been described as well with the first SARS epidemic. Importantly, we saw this to some extent regardless of how long patients had been on ventilators. So within our patient population, we had some patients who actually never made it to the ICU to be on a ventilator. And that an example of that is in A, where you can see arrows pointing out small hyaline membranes along the alveolar spaces. And with increasing ventilation and increasing time course of the disease, we did see that evolve. So in B, we have an example of a patient who had been ventilated for approximately 1 week and had a little bit longer course of disease, and the hyaline membranes are more obvious. Most were in this sort of exudative phase. Some had entered into the early proliferative to even fibrotic phase. And in panel C, you can see diffuse alveolar damage with a more extensive, approximately 3-week course of the disease, as well as small vessel thrombi, which are pictured by the large black arrows. You can see some of the edema in those lung spaces as well. And with the blue arrowhead, there's an evidence of a fibroblastic foci. In panel D, we show the bronchial epithelium, which was actually remarkably intact. Significant squamous metaplasia have been described with the first SARS epidemic, but we really didn't see that as a major finding in any of our 10-patient series. And actually, given the extent of damage to the alveolar spaces, the bronchial spaces were relatively intact. In this picture, you can even see that many of the cells still have their processes. It doesn't appear highly inflamed or damaged. So here are some of those small vessel thrombi on microscopic section. In panel A, we have an H&E showing both arterial and venous fibrin thrombi. And in the panel just adjacent to it, there's a CD61 stain, which highlights platelets within those blood clots. In B, we show at the center of the figure a megakaryocyte that actually has platelets that it is producing within the small vessels of the lungs. And we frequently saw that, we think perhaps more than we would normally see in other conditions, and these may represent native pulmonary megakaryocytes. In panel C, we see the CD61 stain again with a thrombus having numerous platelets within it, as well as a megakaryocyte stained by that CD61 just beneath it. And D, indicates some of the mild lymphocytic inflammation that we saw, which given the extent of the disease was actually not very significant for this type of infection. And here are additional studies that we have presented in the paper showing type 2 pneumocytes in particular, as well as a few macrophages present within the alveolar spaces. Here in the first upper left panel, there's a CD4 stain showing that the lymphocytic inflammation that we saw, especially in a perivascular pattern, had significant CD4 as compared to CD8 immunolabeling, which you see below it. On the right, TTF1 stain highlights some of the pneumocytes to be able to separate them from the macrophages, which are stained by CD68 below it. While there were some macrophages present, there wasn't necessarily an overabundance, but these pneumocytes appeared enlarged and somewhat atypical with a granular cytoplasm, and that may indicate a viral infection. Finally, we did some work with a bioengineering lab, Dr. Brown's lab, on RNA and DNA staining of the lungs. And so here we show in panel A, again, those enlarged pneumocytes with a granular cytoplasm, an atypical nuclei that we supposed were associated with viral infection. And in B, you can see with the arrow, one of these again showing increased amounts of the green staining, which is an RNA stain, which may represent viral DNA or viral RNA inclusion. At the arrowhead below it, we were able to identify a multinuclear or multicellular cluster of pneumocytes that also appeared to have increased RNA. In panel C, we show what we feel may be neutrophil extracellular traps. So there are neutrophils with strands of the red-orange colored material that are actually strands of DNA. And that may be an important inflammatory effect associated with this disease. In D, we show another lung at autopsy prior to the COVID-19 pandemic, just for reference with these stains so that you can see how much more RNA staining in particular is actually present in the lungs of these patients in panel B as compared to panel D. And I will turn this over.
All right, thanks, Sharon. This is Dr. Vander Heide. I'm going to speak a little bit about the cardiac findings. To set the stage for this, when the first study started coming out of China in Wuhan back early in February and in January, there was a lot of concern about cardiac involvement with the virus, and people were specifically mentioning myocarditis, people actually dying of cardiac complications that they thought were directly related to the virus infection. So we were very interested to find out whether that was the case with the COVID-19 disease of the SARS-CoV-2 virus. So with that background, the 10 hearts that we examined in this particular series that Sharon told you we published, the heart weights are about 370 to 600 to give you some perspective. 370 for a male is probably more or less normal. 600 obviously is not. So there was a range of heart weights. Most of them were probably increased, but it wasn't massively increased. The other important thing that we found was that there's really no significant coronary artery stenosis, because a lot of people were talking again about heart complications directly leading to death. And we don't, this is very important to find out whether this could have just been due to someone with pre-existing severe coronary disease that then went on to develop a more typical myocardial infarction. So that was something we were interested in as well. And when we were doing the dissection of the coronary arteries, we didn't see any acute thrombus formation in the coronary arteries, and that was important as well. One thing that we did find that was very interesting was massive right ventricular dilatation. And You can see here in the picture, this is the left ventricle over here. So here's the left ventricular chamber. And over here is the right ventricle. And you can see here the right ventricular chamber. It's much increased in diameter compared to normal. Normally, this chamber should only be about 0.6 to 0.7 centimeters in diameter. And this is more like 2 or 3 centimeters. So this is very enlarged. The other thing that we found that was interesting was that this was often associated with an increase of a clinical marker, BNP. BNP can be elevated for lots of different things, but one thing that elevates it is heart failure as well as lung disease. So it was interesting that when people that had these very large dilatations of the right ventricle seemed to have a very, very high BNP. We're talking about 10-fold elevations in some cases compared to normal. Next slide, please. So to go over to the microscopic, so this was really the important part for us when we did this initial study. Did we find significant inflammatory infiltrates? Because with normal myocarditis, and if you follow me up here to panel A to start, or actually I'll start at B. Normally, if there was myocarditis in the typical fashion that people describe it in the literature and in diagnostic studies, you would see a whole bunch of lymphocytes surrounding these myocytes. Each one of these things that are standing here are myocytes, individual myocytes. They're cut in different sections, plane of sections, so they look a little bit different from one to the other, but they're all essentially myocytes. And you would expect to see lymphocytic infiltrate and actually necrosis of the myocyte as it's being surrounded by lymphocytes. But if you notice here, we don't see that. And this was common for this is exactly the same thing we saw with all the different hearts that we examined. Instead, what we did see was something I'll talk about in a minute, but I want you to focus up here at the top 2 panels because this is important. As I said, with normal myocarditis, you expect to see a large infiltrated lymphocyte. So these 2 stains, CD4 and CD8, these are stains that we use for to sub-identify T lymphocytes. CD4s are the helper lymphocytes, which most people know them as, whereas CD8s are the attack cells, so to speak. So you can see here that even looking at both of these, there's not a real large infiltrate of lymphocytes at all, which is consistent with what we saw in the H&E. You do see some staining. The staining ones here are brown, but you'll notice that they tend to be in the perivascular spaces, but they're not really surrounding myocytes and causing any necrosis like we saw with the H&E. And also just the point here is that there's more CD4s than there are CD8s, the cytotoxic ones. So basically what we did see that was interesting was if you focus back down here on B, if you look carefully where the blue arrows are, you see individual myocytes. You probably can't see it at this power, but there's individual myocytes that are undergoing necrosis, degeneration. You can also see it here in A little bit better. Here's one right here that's undergoing degeneration. And the important part about this, again, there was a single myocyte. It's not surrounded by lymphocytes. And so this is a very unique pattern when we first looked at this. It definitely did not support the diagnosis of a typical myocarditis. A couple more slides to show you here, just looking at endothelium, because one of the things that we noticed when we started looking at these hearts was that if you look carefully at higher power, the endothelial cells seem to be swollen compared to normal. And that's one of the first changes that we identified looking at these hearts, because we were looking for lymphocytic infiltrates. We didn't see it. We said, well, what do we see? And what we saw were these increased lymphocytic size of these endothelial cells. And so this stain here, the CD31, is to show you endothelial cells. And so you can see there's lots of capillaries in the heart to begin with. All these positive staining here are little tiny capillaries. Focus on this one here. This is a little larger one. And the arrows showing you here is probably hard to see at this power, but this endothelial cell is increased in size compared to normal. So we can see it maybe here too as well. So that's one of the first things that we noticed with the changes. And that led us to come up with a different hypothesis for why myocytes were dying. Finally, over here in the lower right panel is another CD4 stain looking for helper T cells. And this is actually a coronary artery, into the intima of a coronary artery. And you notice here there's a few scattered cells in here as well. So we're not quite sure what that means. It's not a significant infiltrate, but there are a few scattered lymphocytes inside the intima of coronary arteries as well. Next slide. So I think we can summarize at this point. This study was, again, the first published series of COVID-19 pulmonary and cardiac pathology findings that we knew about in the United States, because of course New Orleans was an early hotspot, and we were fortunate, as Dr. Fox said earlier, that we had a morgue that was capable of doing these particular autopsies when most people were not doing them because they weren't sure whether their morgue was capable or not. The key findings that we found, as were outlined earlier, diffuse alveolar damage of the lung tissue. And that occurred whether the patient was on ventilator support or not, which actually does specify or does point to the fact that the virus itself is causing the diffuse alveolar damage. Because as many of you obviously know, that patients who are on ventilator support for long periods of time for any reason can develop the diffuse alveolar damage as well. But this occurred despite whether or not someone was on a ventilator. So it's pretty clear that it was specifically due to the virus infection. The other thing that was interesting, we saw a thrombotic and microangiopathic process contributing to the death of the pulmonary vasculature. And that's one of the key findings that when we posted this study initially, people really didn't recognize, at least up front, that this was not really, this really was at its heart a thrombotic disorder, especially when it applies to the lungs. So we called the clinicians over at UMC and said, look, these patients look like they have thrombosis, so you should think about some anticoagulation therapy. And that was early in the course of this disease therapy process. So I think we did at least contribute to that change in the way that they were managed clinically. Then again, we saw right ventricular dilatation. The important thing, again, no significant lymphocytic myocarditis, but we did see this rare myocyte necrosis. So as I said just a minute ago, clinical implications that the consideration of anticoagulation as a part of therapeutic management of patients severely affected and hospitalized by COVID-19 was important. Next slide. So this is interesting. This is something that Dr. Fox pulled up. I'm not sophisticated enough to do this, but this shows you the impact of our early study that we posted on the server. This is the number of abstract and PDF downloads of our study from April to June. You can see that we've had over 80,000 people download a PDF of our study. And on the right, you can see the various countries and that have been involved with downloading the study itself. So obviously, this has had a big impact. We're very proud about this, that we were able to contribute to the literature in COVID-19. But this is a very interesting, obviously a very hot topic. Next slide. So finally, we have some future directions. As Dr. Fox said, we performed to date about 26 autopsies on COVID-19 related deaths. What we're planning on doing is we're doing additional cardiac studies. We're in the process of submitting the paper to circulation to show some of our cardiac findings in more detail, including our hypothesis for why myocytes die in this particular disease. We also have a manuscript from the department. Dr. Bala and Dr. Love are involved in this one primarily, showing the renal findings of COVID-19, and that's under review. Actually, it's under revision at this point. It's been reviewed once, and so hopefully we'll get that accepted soon. And because it's just been primarily Dr. Fox and myself, there's other organ systems that we haven't had time to really investigate yet. Specifically, a lot of people are showing changes in lymph nodes and spleen that we haven't had a chance to look at yet, which we will. The liver also has some findings that may or may not be specific to COVID-19. So our future directions involve, collaborative studies. We've been approached by many, many people across the country, in fact, the world, to do collaborative studies because we have the tissue. So we're obviously going to collaborate with other members of the LSU community and the surrounding New Orleans schools. As you saw earlier, we did already collaborate with Tulane to get those nice RNA fluorescence studies. And hopefully we can examine the molecular mechanisms associated with this severe inflammatory disease and more specifically the thrombotic nature of the disease. So that's what we have today. Thank you for your attention, and we'll be happy to take any questions.
Great, thank you all so much. Thank you. We do have some questions coming in. Someone asks, how are patients selected for autopsy?
Basically, it's by permit. The families have to get permission to have an autopsy because these are not medical legal cases typically. So when they're in the hospital and being taken care of, which most of these patients obviously were because we did get autopsies, when they do pass away, it's important for us to, not for us, but for the clinical team to approach the family and ask permission to do an autopsy. We were fortunate that many of these families were willing to do so.
Mm-hmm. Someone else is asking, were these patients physically active prior regular exercisers, and how can effects of exercise potentially influence mortality, particularly given its effects on cardiopulmonary system?
Dr. Fox?
I think we don't know that their exercise patterns prior to this. Really, the information that we have is mostly just related to their usual state of health prior to coming in with coronavirus. So we unfortunately don't have that information at this point in time. It might be an interesting topic to look back on in the future, but most of them were not disabled or in any way incapacitated. So they were at least at sort of their average baseline out in the community.
Yeah, okay. Did you find the dilated right heart in all autopsy cases? Was their cardiac function test echo done before death?
That's a great question. No, it was not present in all cases. Actually, in this particular series, there was 3 out of the 10 that were involved with the dilated right ventricle. As we've done more studies, it hasn't been as high as 30%, but it's still significant. And actually, interestingly, not a lot of these patients have got echoes in the hospital, especially the early patients, which these 10 cases were the first 10 cases that we had. So, you know, at that point, people weren't really doing, it was kind of catch as catch can in the hospital. People were in ICUs and things were going crazy. And there wasn't really a protocol to look at things. Sometimes people did get echoes, but not very commonly. So again, the findings that we have with the RV dilation, I think, are unique.
Oh, Dr. Vander, are you still there?
Yep.
Okay, sorry. Did the right ventricular dilation correlate with pulmonary thrombosis?
That's a great question too. Yes and no. Yes, in the sense that a lot of the lungs examined had thrombi, as Dr. Fox said. I think the RV dilation is reflective of the pulmonary pressures that are in the lungs. So obviously these people are sick with diffuse alveolar damage, so their pulmonary artery pressures are higher. So I think there's a component to just the overall stress from the RV pressures, probably more important than than actual thrombosis. But certainly, you know, as we said earlier, there's a lot of microthrombi in the lungs. That seems to be a very common complication of COVID-19.
Okay, and if you all have follow-up questions to these, please post them in the chat. Another viewer is asking, did you perform post-mortem COVID testing on the patients? And if so, what were the results?
We did not, because they had testing for SARS-CoV-2 by RT-PCR just prior to death. So in terms of, at that time, especially availability of testing and necessity of testing, there was no reason for us to retest them at the time of death.
Okay. Did you look for viral RNA in the heart?
Yes, actually we did. I didn't show that picture, but we saw similar findings to what we showed you in the lung. We saw increased fluorescent staining for RNA in the heart. So we're in the process of looking more specifically in collaboration with an investigator from LSU Baton Rouge to try to look at actually probes, working at a particular technique called RNA scope, where we actually use probes looking specifically for the virus itself to try to localize specifically where the virus is inside the heart. My thinking is, and I think this is pretty commonly accepted now, is that it's likely in the endothelial cells, because this seems to be a very common complication in COVID. There seems to be endothelial cell infection seems to be underlying lots of the systemic kind of manifestations that we're seeing in COVID.
Okay. What was post-mortem interval?
Sorry, the post-mortem interval, meaning the interval between...
I'm gonna ask, the person who posted that question, if you just want to clarify on that, we'll come back to it. Someone is asking, what does increased DNA suggest, please?
There was increased RNA, but not DNA. So the increased RNA suggests the viral RNA is present. The DNA stranding that we saw is something that is seen with neutrophil extracellular traps. So that was within vascular spaces, for example. We saw clusters of neutrophils with this stranding of what looked like filaments by staining pattern with a stain that is very specific for DNA. And that indicates a certain type of inflammatory process.
Okay. Did you examine the GI tract?
Good question. We've taken a few samples from the GI tract. The problem that we've had so far, I've looked at, I think, in 3 or 4 cases, the ones that I've looked at. I think the problem is, of course, with all autopsies, which gets back to the question before about the interval between death and autopsy. I mean, I think it's variable, obviously. Sometimes we did them quite quickly, within hours, in particular one case, and most of the time it was a day or 2 days after death. So the point of that being that with the GI tract especially, there's a lot of what we call, autolysis that occurs after death. And so the histology of the GI tract in postmortem examinations is really kind of it's sketchy.
Okay. Another viewer is asking, was the amount of pulmonary inflammation higher, lower, or about the same as what you see in other viral pneumonias?
Well, I think I think the important part is that, yes, there's a very large component to the viral infection causing the pulmonary changes. The cases I've seen in my career, I have not seen anything like this in terms of the response. I think many people have heard this term cytokine storm thrown about probably in the literature and even in the media now. Mm-hmm. I think that's really what's going on more than anything else with this particular disease, which is why it's so severe. Other cases I've seen with viral pneumonia, adenovirus and CMV, things like that over the years don't have this kind of a response, not nearly as much diffuse alveolar damage and the reactive type 2 pneumocytes, and things that we see. So I think this is different than what I've seen in most other viral pneumonias.
Okay. Someone is asking, did the clinicians change their anticoagulation practices as a result of these findings and these investigations?
I think at some institutions, they've definitely explored that as a result of these findings, and then sort of the fact that this has been corroborated by others subsequent to our study. I can't speak directly to all of the factors that have caused our clinicians here to change their practices. So I don't know, Dr. Vander Heide, do you?
No, I don't think, we don't have any specific information, but I think looking at the literature that's been published over COVID, I think it became pretty clear worldwide that people started recognizing the thrombotic complications and started managing their anticoagulation therapy, because initially people were concerned maybe this was a DIC type picture, disseminated intravascular coagulation. But they're really, the fibrinogens were higher, but I mean, the platelets were normal and there really wasn't any bleeding associated with it. So it became quite clear that this is a different entity than DIC, so you wouldn't treat it the same. But I mean, I think there was a time there when people were considering, which direction to go in terms of treatment.
Okay, and we have, going back to the interval question, the viewer writes, sorry, postmortem interval equal time between death and autopsy. So I don't know if y'all remember that question, but.
And I think Dr. Vander Heide had addressed that in what he said. So sometimes we did perform autopsy as soon as the consent was obtained from the family, if possible, within hours. And then at times it might be a day or 2 days, depending upon when that death occurred and when we were able to do the autopsy. We were actually doing many at sort of the peak of the coronavirus pandemic here in New Orleans. But we tried to get all of these done as quickly as possible.
Mhm. Okay. Someone is asking, did you do autopsy on patients who tested negative for COVID?
Great question. Yeah, there was, and that was one of the other things that is very interesting about the whole COVID pandemic, essentially, and that is that early on, patients were in the hospital getting treated as COVID, and they had all the clinical findings of COVID, but yet early on, the nasopharyngeal swabs were the tests that were being done. And I think subsequently it's been shown to be only about 60 to 70% sensitive. So, even with a pretest probability of 100%, which these patients had, those tests were sometimes still coming out negative. And that's the problem. So we contacted the clinicians very early and said, look, we've got patients here that we know have COVID from what their lungs look like. And, whether the nasopharyngeal swab is positive or negative, go ahead and treat them that way. So I think there's three cases right now that we actually are waiting for confirmation from the CDC that they are COVID positive, because histologically and every other measure that we have, they certainly look to be COVID cases.
Okay, interesting. Did severity of heart or pulmonary pathology correlate with blood type?
We actually haven't looked at it compared to blood type at this point in time, but now that we have a larger cohort, it might be something interesting to look at in the future.
Okay. Yeah, and this might be something I'm not sure y'all know, but were the comorbidities uncontrolled or controlled with medications such as HTN or DM?
Right, those are controlled. And I'll let Dr. Vander Heide.
No, you're right. No, you go ahead, Dr. Fox.
Okay, yeah, they were controlled. Sometimes at hospitalization, we saw, a little bit of elevated glucose, something like that, near to death. But for the most part, outside, when they were coming in, it was not uncontrolled hypertension, uncontrolled diabetes. They were all on medications for it.
Okay. A lot has been written about the impact on African Americans. Are you aware of autopsy studies elsewhere on non-African Americans and what the findings were for those?
Yeah, sure. That's as Dr. Fox pointed out, that's the really interesting part about our findings, at least initially. Now that have been, a lot of interest generated because of the fact that these are autopsies from New Orleans. I think it's fair to say that the mortality rate amongst people affected severely by COVID-19 is higher in African Americans than it is in other racial groups that have been looked at so far. Both of us have looked at other studies that have been reported, obviously, across the world. And they, of course, reflect different patient populations. The European population is different. The West Coast population in Seattle is different than our population. I think it's pretty clear that the diffuse alveolar damage is common to every group, as you would expect. I think what's also been shown to be common is that the comorbidities are the same amongst these groups. So it seems to be diabetes, hypertension, obesity, kidney disease seem to be a common thread through all different racial and ethnic groups. But I think those are studies that are ripe for looking at. I don't think anybody's looked at potential genetic response differences to infection. There's lots of things I think that can be looked at.
And I think adding to that, it is, I think, an important contribution that our study makes, because some of those other studies, for example, reflect a much older population, or as Dr. Vander Heide had mentioned, demographics that maybe are not as severely affected, but we were able to capture actually somewhat younger. If you look at our age range, 44 to 78, and many of them were in a younger age range than we see the majority of COVID-related deaths, but within the African-American population. And it's an important contribution then to our understanding of this disease and why certain groups are more affected. Interesting.
Okay. And something that y'all were talking about, the differences between the West Coast and here. Can you explain any more about, Dr. Vander Heide, you mentioned findings with the liver. Is there anything you can expound on there?
Not really. The liver, I mean, what we've seen, other people have, well, first of all, I'll start with what we've seen. We've looked at probably livers in probably about half the cases that we've had. Initially, we were so busy, we didn't take the time to think about what we really wanted to sample as much as we probably should have. But we started taking liver early. What we've seen is an interesting changes. And the question, as I said earlier, the question is whether it's specific to COVID-19. There's a couple of cases that had some severe zone 3 necrosis, which is kind of like ischemic necrosis. Others have shown lymphocytic infiltrates in the portal triads. Others have shown, I think this has been reported by other groups, that there's steatosis associated with this, mild to moderate steatosis, which we've seen in our population as well. But there's also been hemophagocytosis seen in the livers in other studies. And our liver expert, Dr. Biven, looked at a couple of our cases and said that he thought he saw some sheared off red cells in some of the sinusoids, which would suggest there's some microangiopathic shearing going on or destruction of red cells. So those are things that we're excited to look at going forward.
Okay. Just a few more questions. Since COVID attaches to the ACE receptor sites and since pneumocytes are particularly rich in ACE receptors, could this explain the severity of the alveolar damage?
Yep, absolutely. I think that's an important point. I think there's also ACE receptors expressed in the proximal renal tubules, which is we've also shown in the study we mentioned earlier that's under revision. We've seen virus in those proximal tubular epithelial cells. And it also seems like endothelial cells elsewhere in the body are also affected. So some studies have shown in the brain, for instance, that there's some thrombi in the brain, which seem to be also associated with endothelial infections. So I think, and again, they express the ACE receptor. So I think there's a real strong correlation overlap between which tissues in the body express ACE and which ones are more likely to be infected by COVID.
Okay. And someone is asking, can you post the reference for the study here? If I can actually post there's some articles on the LSU Health website. I can post those to this chat. And if you all, I don't know if you all have anything, you could quickly post anything for our viewers into the chat. That would be appreciated. And one more question, any clues to the anosmia? I think that's how you say it, anosmia.
Anosmia.
Anosmia, sorry.
It's okay. Actually, we did take a few samples of nasal respiratory epithelium. It's just grossly and microscopically, there wasn't anything particularly unusual, but we would be interested in kind of looking at that further.
Okay. Okay, and I'll take one more question, and then we really do have to wrap it up. Could the ACE receptor aspect explain the difference for COVID damage versus CMV or other viruses?
Yeah, I think so. I think that's exactly what I think we're finding, that the fact that the ACE receptor is so attractive, because this is how the virus enters the cells through that receptor. So that's why it's so correlated. I mean, they actually uses that receptor to gain entry into cells. So that coupled with, I think, the extreme cytokine storm that happens with this particular virus, I think accounts for the lung damage.
Okay. All right, y'all, we will wrap up questions now. We really appreciate it, Dr. Fox and Dr. Vander Heide. Thank you so much for your time and also answering all of the questions. That was a really engaged group. We don't usually get so many questions and so many detailed questions. So thank you all. Thank you everyone for attending today. You can find the recording of this webinar. It will be on our website at lsuhealthfoundation.org/coronavirus. You'll be able to see that and the recordings of all of our webinars, as well as the upcoming schedule for webinars. So thank you all very much. We really appreciate it and have a great day. Thanks.
Thank you.
Thanks.